So good evening, friends. Welcome to this Tuesday evening critical care sessions. We try to bring some interesting areas of topics so that all our viewers, all our participants can get some interaction out of it. So today we thought we will bring some of the recent things which has been in the minds of all of us, but all of us have our queries that is this possible in India? Can this be a reality in India? So that is nothing but a extracorporeal CPR. Suppose a patient who is otherwise young had a reversible cause of sudden cardiac arrest and not responding to a conventional chest compressions or the ACLS algorithm, can these patients be bridged to some kind of circulatory support so that the cause which is caused the cardiac arrest can be reversed and these patients can brought back to the normal healthy life? So that's the topic of discussion, and we try to add both mechanical CPR, that is using some form of chest compressive devices which nowadays is not been commonly used but are available in many of our centers, and also extracorporeal CPRs, even though it is a very what you say skill demanding and resource demanding technique, but yes, it can be done if it is protocolized and pre set of things has been ready. To actually take us through some expert questions, we have Dr. Apran Chakraborty, who has been a seasoned ECMO physician. Sir, we welcome you on board to this session, sir.
Thank you, Venkat. It's a privilege to be here in this webinar, and obviously this topic is very much of importance of today's thing, and this is the next step of ECMO in India. Though we have not achieved much in the out-of-hospital cardiac arrest, but certainly we are offering in-hospital cardiac arrest in some situations, like in cath lab, in ICUs, in operation theaters, and probably in some cases where emergency situations where the patient is brought from outside and it has a quality CPR. So I'll hand over to you for your talk, and let us start with your thing, and then we'll discuss after that.
Dr. Arpan is a senior consultant and ECMO physician in Apollo Hospitals, Kolkata right now, and is a past president of ECMO Society of India, has been a seasoned speaker for all these ECMO congresses and national conferences. We welcome you on board, sir. I'll move to presentation. So,
thank you.
So is my slides visible? My slides are visible?
Yes, sir.
Okay. So today I will be taking you through about extracorporeal cardiopulmonary resuscitation. So why are we discussing this? So it happened to us that in the high-tech city Yashoda Hospital, last 48 hours back, we received a 32 years old biomedical engineer working from some physical company, had some chest discomfort while he was actually reaching to the office at around 9:45 a.m. in the morning, 3 days back. And when he actually received by their office employees, he was taken to some medical center there, and where actually they found that the chest pain was intense, so they tried to bring to a nearest hospital of our high-tech unit. So once he reached to the Yashoda Hospital high-tech unit emergency room, the ER team could actually do a quick ECG and take a cardiac consult, and they could see that the ECG is suggesting a ST-elevated myocardial infarction. And in the meanwhile, the patient started showing a ventricular fibrillation initially with some pulse, and later on, in no time, the patient went into a pulseless state, unresponsive, needing a CPR. From his arrival, 15-20 minutes to another half an hour, the patient had no palpable pulse, so needed a continuous chest compressions. And in the meanwhile, a cardiac team was activated, and this patient used to have a recurrent runs of ventricular fibrillation. and without pulse, and there was a repeated cardioversion done. There is bidirectional also cardioversion done, but in between the patient reverted to ROSC and still continue to have a kind of VF. So they needed some form of chest compressive mechanical devices and try to open those etiological cause with maybe a coronary artery occlusion. So they try to shift this patient to the cath lab with a cardiac team on board. It is a daytime. So through a lift, this patient reached to a cath lab, and in the cath lab, this patient was continuously running a VF without much of pulse, and the angiogram could be negotiated in that CPR status, and they could found a complete cutoff LAD with 100% occlusion, and they did a thrombossuction, and after no time, after the thrombossuction and opening of those vessels, the patient started reverting his VF to a normal sinus rhythm. And then after stabilizing there with noradrenaline, adrenaline, and vasopressin on a mechanical ventilator, this patient was transferred to the intensive care unit with almost a pH of 7, with lactates of somewhere around 8 to 10, severe acidosis, and needed another a half a day of stabilization. And in 6 hours time, this patient started responding to the commands, started eye opening, moving his limbs. And in a next day, early hour, the patient was extubated. And in 2 days time, the patient went home. So today, this patient was back home in a conscious state with normal neurological status. And this is what I'm talking about, the couple of days story in our hospital. So this is a live dynamic example that sometimes these mechanical chest compressive devices, not always the extracorporeal, may also have a role to play in these during the transport, during the procedures, during the cath lab when you are doing an angiogram or angioplasty. So you may need some form of this mechanical compressive devices to help your patients to recover to normal state. So the extracorporeal CPR is something addition to this mechanical CPR. So mechanical CPR is we use some or the other form of chest compressive devices. Some of them has this piston-like phenomenon. Some of them have a completely circumferential brass-like things where there will be a chest compression at a set rate with a chest set depth. And these can be useful during this processor. And then if this is not helping to recover or restore the ROSC in a reversible conditions, we may need to consider some form of extracorporeal support so that these patients will get some time for the reversible cause to be reversed in the form, like if it is a ACS like our case, that can be opened up and these patients can be reverted back. But what are the different challenges we face? So initially, when these kind of discussion happen among any of our clinicians, it feels like, is it so easy to perform, or is it feasible at all to any person to get an extracorporeal ECMO support in such a quick time and in such a compromised condition like when you're doing a CPR? These are few visuals which actually are real time when you can see a patient who is getting a VA ECMO in a metro station in one of these pictures, and there is another patient who is receiving this VA ECMO on a road situation, who has been supported with an VA ECMO. And these are few other visuals which I could actually get from the internet, where ECMO has been initiated in one of the museum where the patient had crashed with the light supported by the bouncers. And we have one more patient who has been rescued from an apartment with an ECMO on place. So these are the visuals which suggest that these are not, even though they are rare, but these are all been done in different locations where it is not an easy task to be achieved. So actually, this is the last week when actually I went to the ELSO registry and tried to see the number of eCPRs done in different age groups and specialties. If you can see in adult, out of 1.3 lakhs ECMOs, around close to 17,000 are ECPR based. That means close to almost 12 to 13% or 14% of the whole total ECMOs which are initiated were of extracorporeal CPRs. And the interesting part is survival to discharge or transfer is close to 30%. In any form, if you took at a regular conventional CPR done in a out of hospital cardiac arrest or in hospital cardiac arrest, probably the intact neurological discharge state may be close to 5 to 10%, not more than that. But in this case, you can see that is around close to 30%, something which is interesting. And this is not uncommon. That's what I was trying to say. Keep ECPR, even though we all believe it is not maybe a common scenario, but it's not uncommon looking at these numbers. It is almost close to 15-20% of the total ECMOs which are done. So what is the status in India? I think Dr. Arpan will comment on this. This was a recent actually survey, web-based survey done by Dr. Oza and Dr. Sunil Povani and his team, where they could actually see that when they interviewed around close to hundreds of intensive care team, majority of them didn't have any experience of CPR or lack of any exposure to them. And many of them feel the feasibility or due to lack of equipments and financial issues are the most common causes. Interestingly, many of them, these clinicians who actually expressed, they are not aware of such phenomenon which is possible in Indian context. So something this probably gives us an insight that ECPR in Indian context is still not a known phenomenon happening, and many of us still don't actually believe that this is possible or feasible in Indian context. So actually, when we actually look back our own data in the couple of years in all our units, we could realize that out of our 150 ECMOs which we have done, around 5 are can be considered as extracorporeal CPRs, which are done peri-arrest situation or impending arrest situation or after the cardiac arrest. So these are the cases which actually also we get these ECMO patients not just from our own units, but we had around 108 transfers. But most of them were electively done somewhere outside, and they were transferred to us in the last 3 years time. But the 5 ECPRs which are initiated were those actually who presented to our emergency department in the last 2 years or so. So the first patient which I will try to give you an insight, which we happen to be a part of witnessing that where a 30 years old lady collapsed perioperatively during a oocyte retrieval from a IVF center. And then the patient suddenly had a cardiorespiratory collapse, and the anesthesia team and the treating team started a CPR there and transferred in an ambulance to us. This patient started having some amount of ROIC in between in the ambulance and in our ER also. But in no time, this lady again gone into a the cardiac arrest with no pulse. So this patient needed a continuous CPR. And it happens to that the family has a known medical fraternity. So they all were also keen to actually not not leave any stone unturned. So they want every form of support, including the possibility of an ECMO in this context. So we will discuss that case. That was one of the case where we could actually do a ECPR. There was another case which was admitted to our cardiac unit into the wards for waiting for a heart transplant, probably for a dilated severe cardiomyopathy with restricted life and limited movement. This patient suddenly had a VF in the ward, and CPR was initiated after a code blue activation and was transferred to a CT anesthesia OT suite. And there, after a repeated attempts, the VF was not converted or not been reverted back. So they initiated a VA ECMO in the OT. That was a second situation where in a peri arrest there was a ECPR done. And then coming to there was a lot of interventional airway work which is done in our units, being a very leading interventional pulmonology unit. Tumor debulking was done for an airway tumor, and during the tumor debulking, one of our patients suddenly decompensated because of airway compromise and went into a cardiorespiratory arrest and needed a CPR, and then further initiated into a ECMO to actually support that debulking surgery later. We had one more case like what I mentioned just before, that ACS, interval MI, out of hospital cardiac arrest, mechanical CPR, cath lab, primary PTCA done, still not actually picking up the pressures, severe circulatory collapse. So there was a ECPR initiated in our unit for a 2 days or so. And this is one more case where we initiated that the ECPR kind of thing, where the pressures were almost non-recordable and needed a mechanical CPR with a ECMO initiation. There was a young other girl who actually had a massive beta blocker and calcium channel blocker overdose. And this patient landed in impending cardiac arrest with not responding to any form of vasopressors in the ER, and no circulation. So in this patient needed a CPR, and parallelly with the CPR, the ECMO is initiated in this case. So these are the gross overview when actually retrospectively saw all those possible cases where we could actually initiate a ECMO in different contexts. So the first case which I was actually talking about is the 30 years lady, where the mechanical CPR was initiated, ROSC achieved in between in the ER, but during the ambulance transfer, during our ER, the patient will repeatedly go into a cardiac arrest. And in that time, because the patient is repeatedly going into a cardiac arrest, we initially thought about 5T, 5H, but no clue why this patient, otherwise a healthy young lady, went for a oocyte retrieval, suddenly crashed there and not reverting back, and echo is hardly contracting myocardium. So in that situation, it was a daytime. So luckily the ER team could actually give a call to the ECMO team, including the CT team, the intensivist, the CT anesthetist, and ER physicians, and all together could initiate in 20 to 25 minutes a ECPR, a VA ECMO, and this patient were cannulated. Both the femoral cannulations were done, and in a 24 hours time, we could actually see the myocardium getting better, because probably we felt that this can be an anaphylaxis or a stunned myocardium. And in 24 to 48 hours time, we could actually start weaning the ECMO and decannulated this patient in 48 hours time. And this patient was discharged home in less than 5 days time in a healthy state. So these are kind of a very, very, what do you say, sudden episodes where sometimes we don't have any clue why did this patient had a cardiac arrest, what was the reason behind that also. So initiating such a supportive device where your regular CPR is not helping has caused the back. So after these cases of ECPR, we realized a few challenges which we face in Indian context. Okay, so it was a daytime. So we realized the ER team could activate, and the patient's family was known medical fraternity. So they understood the seriousness, and they understood the need of a kind of extracorporeal support, and the cost incurred in that, and the risks and complications of this procedure and outcomes also. But it may not be true for all situations. So availability of team round the clock, suppose it would have been happened in the middle of the night, or on a holiday, or on a PH or a public holiday time, it would have been not easy. If any of our team members are occupied with some surgery and all, it would have been a challenge. So we realized that making availability of a ECMO team, and actually coding this ECMO team whenever there is a reversible cardiac arrest, where the CPR has been initiated, and this team also keeps a watch, is the need of the hour if you really wanted to develop the ECPR. So we made an attempt to create a team with the ECMO physician, with the vascular teams, vascular surgeons, and CT anesthesists and CT surgeons, any of them in permutation and combination, making themselves available if certain situations arises. So that is one step. That is the first step which we felt key. If we really wanted eCPR, we need to have a team which can actually reach the site in no time. Second part is patient selection. So this is again a very difficult task which we will be discussing. The patient selection, whether it is a age group, whether it is a reversibility, whether it is at what time limit you wanted to start the eCPR. And then the interesting part is consent. These cardiac arrests suddenly happen. There may not be family member available, and the ethical issues and maybe later on the cost issues all will come into it. And location, can I do it in ER? Can I do it on the site of the injury or the site of the cardiac arrest? These are all again a challenge. So in India, we will talk about the locations at this point of time. We are only shifting this patient with a mechanical circulatory support, like a mechanical device using to transfer this patient to our emergency room. And we are trying to initiate in emergency room itself. We are not trying to actually attempt at any of these eCPRs on the road or on any other location. Yes, there were situations where another hospital where the CPR is done, this can be an option. But again, the time is the problem there in those situations. Cannulations, I think the only option in these situations are femoral cannulation, because there will be ongoing mechanical CPRs. Either in the same side. See, the cannulation will not be easy in the chest when there is an ongoing chest compression and you hardly have any pulse felt. So most of the times what we do, whenever we try to actually puncture either an artery or a vein, we cannulate them with a guide wire in place, so that whenever you want to exchange them through your bigger guide wire and your ECMO cannulas, that is an easier way. So either a venous cannula in the femoral vein on one side, or both artery and vein, or one femoral cannula as a vein, the other femoral cannula as an artery can be an option. External cardiac massage, it need to be continued till you secure this VA ECMO and you have an adequate circulation. So that was an again challenge. These patients need an external cardiac massage, and if the patient had the continuous VF or VT, cardiovert defibrillating them and making sure that none of your surgical team or those who are cannulating doesn't get electrocuted by this defibrillation, need to be very careful. And in the meanwhile, working for the reversibility of this cause of cardiac arrest. Suppose we are talking about anaphylaxis, something like adrenaline, or a reversal, the cause like if there is a ACS causing a LAD occlusion. So again, you need to look at those also, just not bridging it with a VA ECMO, but why did this patient had a cardiac arrest? How do we reverse it back? If it is a VF, what are the cause of this arrhythmias? Is it ACS or something else? How do I revert it back? If it is a poison, if you have an antidote or you have a filter to filter out it, all that need to be parallelly done. Then the biggest challenge we realized is neurological status. If the patient regains his sensorium, out of our 3 cases, I will talk about 5 cases, I will talk about what happened to them. All cases cannot be a green or happy endings. We had the 3 cases where young patient who had actually oocyte retrieval has recovered to a normal state in no time. And our poisoning lady, that beta blocker and calcium channel poisoning lady, has recovered, and the airway procedural patient has recovered to normal state. But the 2 other cases where we initiated this VA ECMO after a PTCA for a prolonged period of low circulatory status or circulatory pressures, in those cases, the neurological status did improve in spite of a couple of days of support, and the myocardium didn't take up. So we at certain point of time had to take a call on the futility of this. So neurological status and reversibility of the cause for which you are attempting this bridging also plays an important role. So weaning and withdrawal in futile cases where you realized after a certain amount of time trial that the patients are not going to improve, those are again challenges, and ethical issues comes in India as a normal challenge. Selection of the ECPR cases. So the selection, we use a criteria close to the also criteria that we use a age group of less than 60 and a witnessed arrest and a CPR initiated within the 5 minutes of time. And the patient don't have any critical illness, which can be a terminal illness. So these are the things, and there is a immediate CPR initiated and reversible cause has been noted. But in India, the selections are added to many more, where the cost of ECPR has to be most of the times borne by the patient. So when you actually talk about a cost and ECPR being a costly affair, and it needs a lot of resources and probably the circuit, kit, oxygenator, and all this itself costs a lot. So that will be a probably a challenge in Indian context when it is borne by the family or the patient himself. And we also are in an atmosphere where on many of the times we have been seen with lot of what you say vigilantly, that whether we are misusing them, and we have many situations where there were movies created saying ki we treat dead patients, and that is not uncommon in making our efforts as difficult in ECPR, where you are already know ki we are dealing with a patient who is had a cardiac arrest, and you are doing CPR and initiating a VA ECMO, and probably waiting for some reversibility to happen in those cases. So these are the different clinical situation, different situation in India. India is a different country altogether. So we carry on with so many emotions, and the days are changing, how people look at our profession at this point of time. So as I mentioned, so if I have a younger age group, witnessed arrest, CPR less than 5 minutes, VT, VF, and you have a rhythm which probably looks like because of arrhythmogenicity and recurrent ROSC, a sign of life. When you actually see a patient opening eyes, blinking, some jaw movement, some limb movement. So these are probably a signs that still I have a cortical intractability in them and absence of terminal illness. And probably you know the patient has ACS, embolism, or a drug intoxication, where you can actually reverse them is a way forward. So the team which we discuss about in our hospital is a ECMO physician, like we have Dr. Arpan, we have Dr. Sri Charan, who actually dedicatedly work in ECMO ICU. We have a CT anesthesiologist who has been expert in initiating these ECMOs anywhere. So we also take vascular and CT surgeons. The vascular surgeons are a recent addition, and for a percutaneous procedures, they are of a great help. Whenever we had a difficulty, these are the team members who actually been really helpful in actually doing the percutaneous, both arterial and venous and distal cannulation. That was one of the great, good addition which we realized. Perfusionist, ECMO nurses, and ECMO kits. These are the few things which always been should be available if you really wanted this to be run. And again, this is a list of equipments which we felt are required when you are talking about a ECPR. All these requirements, I will not go into the details. We made a list which are required in them. And timing, the timing of initiating of ECPR is always been under the discussion. See, we take around 15 to 20 minutes as a time to start a ECPR if my the regular conventional CPR is not helping, and I probably think that there is a reversible cause, and 15 to 20 minutes is the time where if at all, the family is affordable and interested, and the whole team is available, and we need to start the ECPR by 15 to 20 minutes. But again, if you start after 20 minutes, that will be again going to take another 20-30 minutes to arrange things. So the common recommendations are, if you at all you wanted to initiate a ECPR, your team should be activated the moment you see a patient having a cardiac arrest and there is a reversibility. So initial minutes only you alert them. If the patient achieves a ROSC and the patient is been reverted back to normal sinus rhythm and been channelized to the reversible causes, then that's fine. If the patient doesn't revert back after 15-20 minutes, probably your team is there to initiate this. That is what one of the recommendation which we are thinking about. But around 15 to 20 minutes of conventional CPR, if the patient is not responding, probably that is the time where I think we should initiate an ECPR. That's what we take as a timeline. So there were different studies which suggest ki if you delay ECPR after 20 minutes, you actually kept on increasing the chances of survival and probably a maybe meaningful neurological recovery. So that is again equally important. You may revive a patient, but if your neurological intractability is not there, then yes, you may not have any sense to do that. So somewhere we are talking about 20 minutes being a timeline. So this is again another term. If you start things in 6 to 20 minutes, you have a much better outcome than as the time progresses. So on scene or hospital ECPR, I think scoop and run or stay and treat approach. In India right now, we are shifting these patients with a mechanical supporting device to a ER, and there only we are initiating. On site, I'm not sure. We don't do it, and we'll take some opinion if we have any scope where we are doing it. Cannulations, I think most of the times we prefer somewhere femoral artery cannulation 15 to 17, and in a percutaneous way, if the body weight and height is less. So initially we start with the 15 French cannulas, and femoral, the draining cannula can be somewhere around 17 French. So both the sides, femoral arteries and one side vein, one side artery, or unilaterally both vein and artery can be cannulated. This is overall a flow which we can use the timelines which were given, different steps. So if suppose in 15-20 minutes, if the patient is not achieving, then ECMO team is alerted, monitor the CPR. If the patient is not reverted back, so cannulate and initiate ECMO, and then you take the next step like distal cannulation and LV decompression later. So first step is to initiate an ECMO and restore back the circulation in those initial 4 to 5 steps in a timeline of maybe 20 minutes to 30 minutes. So again, we were talking about these all checklines from insertion to the checking that that no air bubble is left behind, and remove the cramps. Probably initially start with the 3 to 4 liters of blood flow, and then slowly once you achieve this blood flow, slowly stop the chest compression. And for the initial period of that, you probably need that chest compression to be continued. So this is again a flow which has been given from a bystander CPR to initiating a ECPR, and then probably reverting back those primary reasons why the patient got arrested, and then following the same, we are now following normothermia and probably maintaining the cellular homeostasis, normocapnia, and probably the oxygen levels within the normal limit, not making a lot of hyperoxia. That's the status now, and the patients recover with that. So this is again algorithm post ECPR. Maybe anticoagulation. We don't do any hypothermia nowadays. Normal oxygenation. That's where, and TTM has not been now the target. We avoid a fever nowadays in many situations. So this is again a recently published systemic review, which actually taken all those trials which are done, not just observational trials, but also this has taken few of those randomized trials which are done in the recent times, suggesting there is a favorable outcome in the patient who received a ECPR compared to the conventional ones. And there is a neurological recovery also has been significantly better in the treatment group than the controlled group. So we hope these informations probably will help because in the recent times, we see a lot of negative trials than positive trials. So my take home is, see, like a mechanical ventilation, maybe 3 decades back, we were used to think that any patient who will be initiated on a mechanical ventilator with an endotracheal tube has a very less chance of survival. Similar way, now we still have that probably mindset that extracorporeal membrane oxygenation is far away from reality in emergency situations, but it may not be true. Taking it forward, if we have a patient who is young, who has a reversible cause of witnessed cardiac arrest, and the patient didn't achieve a ROSC, and you initiated that from the beginning, that your team is on board, and within 20 minutes, if the patient could not reach restore his normal spontaneous circulation, you consider initiating ECPR if the patient's family is available and affordable, or your institution has a policy of at least keeping a kit available for these kind of patients. And you treat the cause, whichever is the reason for the cardiac arrest, like if you have a poisoning, if you have a patient with a coronary occlusion, or a patient with a thromboembolism. So those causes need to be reverted back. This doesn't happen overnight. I am telling you, we did all these cases initially by coincidence, because it was a daytime, the team could have been come together. But if you really want this to be run over 24 hours time, you need a complete preparation, protocols on board, kit to be available, cannulas to be available, your perfusion team should be ready, your ER team should be aware, your primary clinicians who refer this case has to be have an idea, the code to be activated like a code blue, coinciding code ECMO or code ECPR, and a predefined pathway should be available, and a mock drill should be done like what we do for a code blue drills, so that you actually simulate this kind of situation to cannulate these patients. Evidence and literature is evolving. I do understand that we don't have a robust data from India, but when I spoke to many of our senior colleagues, including Dr. Arpan, Dr. Oja, and many, all of them had on and off pockets of experience here and there, where they have to actually initiate ECPR in a very crucial crisis situation, in a impending cardiac arrest, and they all have some or the other form of mixed response of recoveries in them. Some of them did really great, and some of them, in spite of all these efforts, could not make a difference. But if we use more and more, probably we'll get more and more the information. With this, I think we will take questions and probably open. So we invite Dr. Arpan for the comments, and then we'll take questions. Dr. Arpan, are you?
Yeah.
Please.
Nice.
Comment on this.
Yeah, nice talk. Enjoyed it actually. So comments, I think you have left nothing, no stones unturned, and the 4 C's are actually important in if you are starting a ECPR program, or you are going to start an ECPR. This is the cost, consent, cannulation, and the continuation. So cost is a problem, and I don't know how to solve this issue, but we have some suggestions from our side, which I'm going to discuss after all. Consent, obviously, it's a problem, particularly in out-of-hospital cardiac arrests, patients brought by some other people, or there are bystander CPR whom you don't know who are the relatives and whether they will come or not. They're over phone. They don't know. They're in the sudden. There is a suddenness of the issue. So consent is a problem. Who is going to give the consent? Third one is the cannulation. Obviously, who is going to cannulate, and what is the mode of cannulation? It's a percutaneous or semi-percutaneous, or it's an open cannulation. So getting a vascular surgeon over a 24 hours period is not a very good, not a very good availability in our situations, obviously. But if you get them, if it is in office hours, you will get them. You will be happy to include them in your team. But we have to have to learn the percutaneous cannulation in these scenarios, because this is the only thing which has improved the outcome of ECPR, because within no time, probably less than 10 minutes time, you can put 2 cannulas in the groin, and that you can help the patient to come out of this shock situation. Fourth one is the continuation. Obviously, what is the low flow period, what is the no flow period, and how the brain is going to react on it. After that, whether you are going to take directly to cath lab or you want to wait till the patient is getting awake, and then these are the lot of questions will be asked in your mind, and it will happen during this kind of ECPR situations where you are going to get into. Now, how we are going to do these things in our country, that we have to categorize ourselves. It might not be the same in Kolkata, it might not be same in Hyderabad, it might not be same in Mumbai, but we have to rationalize our things. Like if you can tell, say, I will do ECPR from say morning 9 to 5. So because this is the time where all the people are present, any arrest during that time, the ECPR can be done. So this can be the one thing, the time constraint. Second is the place. So if somebody tells I will do ECPR only in cath lab and only in the operation theater, where everything is available, any kind of arrest I can address. I will not go to do the ECPR in emergency where there is a problem, there is a suddenness, who is going to give the consent and all these things. Later on, when my team is they are the master enough to do ECPR on their own, then I extend my ECPR services to the emergencies or for the out of hospital cardiac arrests. So these are the ways you can rationalize or you can customize your ECPR programs. Otherwise, it would have been very difficult. If you start your ECPR program from emergency, that is going to be a big failure, because that is the area where you should not start the ECPR. And probably the cath lab is the area where you should start ECPR, because everything is there. You can cannulate, you have a sheaths in the groin in place where you can just redilate and push the cannulas. So these are the ways we do. Now, cost. How do you reduce the cost? Many of us has taken the bypass route of using a simple oxygenator, not using the ECMO oxygenator initially. The simple oxygenator, what we use in the operation theater, costs around 20 to 25,000. And with the cannulation, the costs come down to 50,000. You do the ECPR, put the patient on ECMO, and the circuit goes for 6 to 12 hours at least. By that time, if the patient stabilized, patient is started opening eyes, then you change the oxygenator to a costly one for another 4, 5 days, 7 days longer run. So by that way, you can reduce the cost. So these are the small things which we are trying to customize our ECPR programs in different institutes in a different way. So these are the things I can add on to your talk, if we can remodel our.
Yes, I think we need to be very careful in Indian context. As I already mentioned not all patients' families will be same, not all hospitals infrastructure will be same, and any form of ECMO support system, either in ER or in the cath lab or in the OT, is labor intense, and that needs a technically very demanding supporting system with a manpower or the equipments, gadget and all. As the volume goes up and you start getting exposed to more and more numbers, it may feel like, okay, this has become a routine because all your system, all your manpower, everybody gets acquainted with it, but it is relative to all your other, what you say, supporting systems. ECMO remains to be one of the complex one. So as you rightly pointed out, what we do in our organization also, we discuss with the management, and we are probably happy to say that our management is keen to actually dedicate a kit available with a set of things that, okay, if there is an emergency and sometimes you may not have a financial clearance in a patient who is really in need, and count it as an extra kit as available for some contributions from the management or somewhere, and it can be initiated in that. and rightly suggested by you as the cardiopulmonary circuit kit, which we use for the intraoperative period, can be an option to initiate with. But the only challenge will be, again, you have to change in a 6 hours time. So you will have that risk of changing from this to. So my first question will be, if at all I use a cardiopulmonary circuit, which we use for the cardiac surgeries or open heart surgeries, now, will the circuit also need to be changed there? Because that circuit will be a different from what, if suppose I use a cardiopulmonary circuit with the oxygenator, and then you have to change the complete one in the later half if you want to change the circuit plus oxygenator.
Yeah, because your oxygenator, what we use in the operation theater is basically it is not a centrifugal pump. So and that is that's why the cost is low. And whenever you change it, you just change it with your the whole circuit. So you change from the cannulas, cannula to cannula change happens whenever you change these things.
So how difficult it is to change? Because we in our 4 or 5 cases we could not do that. It is only a direct, we have initiated an ECMO. But what was the experience of you? Any experience of changing from that to there, and what was your experience with that?
Yeah, we have done many a times actually, and the change is not a very problem. Only thing, you have to shut down the circulation for probably a 30-second maximum, because everything kept ready and everything just pre-connected, and just you have to cut it and just connect it, two pumps. So that is, change is not a problem. Only problem is that sometimes these cardiopulmonary bypass circuits are not very much it cannot be predicted how long it will go. You are thinking that it can go for 6 hours, but it might clot within 2 to 3 hours. So you have to be very much cautious about heparinization and everything. Might need more heparinization, because they are not the long circuits, or they are not the silicon oxygenators what you're using regularly. So that is one point. But I'm just telling you, because it's a cost constraint, and you just keep the patient alive, putting the patient on bypass, and just see what is happening. What is happening to them? Whether the patient is getting awake or patient is stabilized after that. Patient, we got some rhythm ROSC on after putting on ECMO. So for that purpose, that is a fantastic one. And on the top of that, you can arrange the circuit with a machine.
Prime the circuit and keep it.
I'll not say priming, that you can keep it as a primed circuit or as a assembled circuit.
There are centers who actually keep these circuits primed and ready, who are high volume circuits where initiation is common. So is they use this whenever they initiate an ECMO, either a ECPR or a regular ECMO, they initiate use that?
Yes. You can use it because your the recommendation is if you have not opened the circuit, only just prime that it can be used for 30 minutes, 30 days.
30 days. So that period, if they initiate any ECMO, they use it, and again one more circuit. So that one of the ways where the most of the centers do in that way, if they are a high volume center and the ECMO has been a routine regular process. There were some questions which will take Dr. Arpan. The questions are, somebody is working in a tertiary care center, Dr. Chandramouli, and he is in a metro. So he's asking, can I initiate ECPR? If I have to initiate ECPR, what will be my subset of patients where I will consider ECPR?
Subset of patients should be what you have shown, that the younger patients, you should try the younger patients. The studies which have came for successful ECPR are almost all are in MI patients. So this shockable rhythm, MI, witness cardiac arrest, and younger population. These are the 3-4 agendas you have to keep in mind to start ECPR program. Otherwise, it is not going to be helpful, because you put the patient on ECMO, but ultimately the outcome will not happen, and people, obviously, the bad name will be given to that ECPR program. So for that thing, it's a shockable rhythm with MI is the prime case for your ECPR to start an ECPR program. And the second one, which is important, more important, like I don't know how much prevalent it is in your place, but the self-host the calcium channel blocker and the beta blocker poisonings, which are purely reversible if you treat them early. So they sometimes comes with a recurrent cardiac arrest.
True.
So this is
So,
another case. And third one is obviously the pulmonary embolism, but it's very difficult to identify pulmonary embolism with cardiac arrest at that point of time. You have to go for a CT angio and all these things after that. So probably an MI with shockable rhythm and the your this poisonings. These two are probably the you can attempt some success.
yeah. So, Dr. Chandramouli, to answer your question, as already Dr. Arpan clarified, we as an institution also reviewed the indication from here also, and we try to actually cut down the A's. See, A's is a number where a country-wise you, with your standard normal A's limit, you can actually modify. We in our unit consider any patient less than 60 or 50 as a younger group and do it, and it may vary from institutions to institution. But as he said, if a patient has a witnessed arrest and somebody has a sign of life, and you can reverse it back, and after 20 minutes of regular conventional mechanical CPR or your conventional CPR patient is not responding, and you have resources and affordability on your hand, I think you have a reason to start a ECPR. It is just a matter of time that over a time you will get exposure. There was another question related to more data on out of hospital cardiac arrest. Any reason to initiate in-hospital cardiac arrest, ECPR in hospital cardiac arrest?
In-hospital cardiac arrest, I think the everybody starts with the in-hospital cardiac arrest. That I have told that in-hospital cardiac arrest where it is mostly common, like in cath lab, in the operation theater, in ICUs where a patient suddenly got arrested, or in post-op patients. So these are the patients that patient you have told that oocyte retrieval case. These are the cases. These are sudden, unexpected cardiac arrests, which are otherwise in young patients, which are not being explained by some other reasons. These are the cases commonly happens in our hospital sometimes. We have seen that one or two case happens when yearly probably. And these are the cases you have to salvage them, otherwise they are going to die. So probably these cases are the recipe for in-hospital cardiac arrest.
So in our 5 series also, couple of cases were in hospital. The patient who had a VF also was admitted to us for waiting for a transplant, and that patient through a refractory VF, and that patient needed a kind of rescued. But yes, it's not always the green side and not always the happy ending. Sometimes you get stuck. In that case, we got stuck. And neither we got any lung heart for the transplant, and neither the family could afford for a longer period. And with the VA cardiac ECMO on place, the patient is alive. So that ethical dilemma comes. There is a lot of discussion comes to there. So there is another question like whether ECPR pathways are available at our centers, and are they working for 24 hours? Is it available in your center, sir?
We have not yet launched that ECPR programs for 24 hours, but obviously for in-hospital cardiac arrest, there is a code ECMO. So if we can, the buzzer, put the code ECMO. Obviously, not always. I have not put it in emergency. For selected cases, they can call us. I have not started emergency, but in cath labs, in operation theaters, and in ICUs, they can call the code ECMO.
Okay. So we did had a flow which we actually taken from the different guidelines and made a flow. But availability of the 24/7, as I said, there will be a critical care guy or a ECMO physician who is available, but all the other staff round the clock availability is not easy. Probably we are trying to make our perfusionists who are available with the cardiopulmonary cases in the CT ICU as a team member around the clock, and the critical care guys who are available as one of them, and then add 1 or 2 personals in the night time if it happens. And but yes, round the clock availability has to be a process, not it happens in a daytime. But whenever is possible to initiate with, we always try to start on daytime. not on a odd hours when supporting hands are not there. But yes, as we all know, it can happen on any time. So the feasibility should be always extrapolated. Is there any difference in outcome from different mechanical CPR devices? I think other than Lucast, we are now having a couple of more in India, and Lucast availability has been again a challenge. Any experience with that, sir? That the mechanical compressive devices.
Not
So
yet, not yet.
we used both ones, one with the compression one, which is the Lucast one, which we had a good experience. But the now the other variant where there is a circumferential chest compression, like it is not like a piston, that devices are equally effective, and it feels that the injuries and probably the rib fractures and the complication related to the chest are relatively better with them in many situations. So I think that is the only extra things which we could actually add. So I think, sir, we had answered most of the questions. So any take home messages so that from the ECMO physician part and ECMO society, anything? So I think we should start collecting the data across. Every hospital had some experiences. So if we can create a registry so that this will give a direction. And as you said, some kind of maybe a position statement saying, as you said, in a resource limited settings, how do we extrapolate the cardiopulmonary bypass circuits with oxygenators initially, and then switching over if there is a cost challenge in Indian context, and probably the ETO cannulas, if available, a set probably contributed by either a management or some contributor, keeping it available at the ER, and no questions asked why it is used without a clearance, has to be made feasible, so that the ECMO team, see, one side is the skilled manpower, the other side is consumables, the ECMO kit, oxygenator, cannulas, all that. So sometimes if things go in a right direction and you make a patient survive and the patient goes home happily, the whole the surround atmosphere is happy. But if it doesn't work out, then all of you are into a difficult task on board. So what will be your take home points to all of us?
That we have discussed in our forums, and probably you are also there at that system, that the ECPR has become a new, it has to be a new step in our ECMO programs. But we have to keep in mind that until unless we have a robust ECMO program running, and you have a few people, not one guy or not two guys, we have a good team who are manning a lot of ECMOs, we should not start ECPR program, because that is going to fail. That is going to fail because you can't perform the same thing during these crisis situations. So every now and then, if a new center was started just now or for 1 or 2 years, not done many ECMOs, but they're getting a lot of cardiac arrest cases, if they ask you that we should start ECPR or not, the answer from my side is no, because that will hinder their program, and that will cause a lot of back things in their program. So it is not advisable to them. Obviously, for the centers and the people who are doing ECMOs for a longer time and done a lot of ECMOs and got a high value centers, they should start ECMO programs. And as I have said, the timing should be there, that I'm going to do ECPR from this time to this time, because the expertise is mostly available at that point of time. The places should be demarcated, that I'm going to do in cath lab, in the operation theater, not in emergency. Last to include the emergency, because we always think we should start doing ECPR in the emergency. That should be the other way around. That should be the other way around. Emergency should be last there, because you are getting, that is the highest point of ECPR you are giving to that. So do it under control environments, like in your cath labs, in the operation, even do it in your ICU, then go to the emergency where you are exposed to the unevenness of your cases. So this is my thing and probably will come with the position statement. We are working on that.
So distal cannulation, or the distal perfusion cannula, which we don't immediately try to do, but may take some time for that. So, what was your experience in that?
Because I don't waste time to put disruption cannula at that point of time. We just put two cannulas, the venous and arterial, start flows and all these things, and then call the surgeon to get the disturb. Because sometimes the arteries are small, they are in shock, they are in 20 lactates, they're in vasopressors. If you poke them and there is a bleeding, there's a hematoma in the groin on a running ECMO, it causes miss. So better to have a opening your superficial femoral artery and or you put a cannula by a surgeon, but that should be in a controlled environment. Because distal perfusion can wait for another 3 to 4 hours, but immediate the ROSC can be achieved by putting two cannulas in the vein and the artery, which is going to supply the circulation. So don't even think of putting distal perfusion cannula in during that time. Don't even think, because it is going to just linger your thing, and it is going to just spoil your game. So don't even put the distal perfusion cannula at that point of time.
Okay, I think with that information of we may have our position statement from ECMO Society of India, and probably we get some more guidances. We thank you for your experience sharing, and I thank all the participants who are there in listening to us and being interactive with us. And we'll continue this endeavor of actually creating some interaction among all of us. We thank Dr. Apran Chakraborty and all the participants and
Thank you.
Thank you.